Yes, Alana?
Are you ready to begin, Dr. Francois?
Yes, it's time to start.
Okay. Welcome everyone to Oxygen Therapy and Critical Care, the case-based series. Before we begin, just a few reminders on the screen for you. We will be using the chat box today for all question and answer. So if you have a question or an answer or a comment, please send that through the chat and feel free to introduce yourself. If you run into any technological issues, send us a message, chat, or WhatsApp. And this session is being recorded, and your attendance is consent to being recorded, so thank you. So today's session is, the topic is essential emergency and critical care. We're on session 11. The date is March 16, 2022. This is our second last session. Time has really flown by. And we, as usual, have the following educators with us today. Leading the presentation is Dr. Francois Xavier Uwimana from Nyaurugenge COVID Referral Center, or former COVID Referral Center. We also have Madame Liberata, Dr. Joseph, Dr. Venuste, and Dr. Apollinaire to help us with the content today. And so with that, we'll pass it on to Dr. Francois to get us started.
Yeah, thanks, Alana, for the introduction. To the audience, today we are going to have our session 11 talking about essential emergency and the critical care. In general, it's a kind of structural session or organizational session where we need people from this session to have in their places, in their setting, the way they manage the critical cases after understanding what is the critical and what is the emergency. To remind you that this is the session where, which is before our last session, which will be held on 3rd March. So we are having the one session to finish our 12 session course. Before we get the general certificate, we will discuss about the modalities of getting that certificate just at the end of this session. Be ready and have careful and be careful in following this session. As usual, we are having case-based discussion from the case we managed in our settings. Today, the case we are having is a 61-year-old male presented to the emergency department with shortness of breath, dizziness, and diarrhea for 7 days of duration. And as we are working in a rural hospital, the nearest hospital with the critical care services being at 2 to 3 hours, like most of this hospital in our country. And the nurse is calling you to assess the patient in respiratory failure. And the question here comes in mind is like, how are you ready to care such patients at your hospital before transfer? And what do you understand as critical care services? So the following learning objectives will help us to understand how we can deal with such patients once is presented to our hospital. Next, please. The practice change objectives we are having, we need to explore acute care, critical care, and intensive care. We list domains across which acute care can occur, and we recognize the critical care continuum just from the beginning, from the presentation of our patients. We define essential, emergency, and critical care. We recognize that the critical care has 2 key domains: identification of critical illness and the care of that critical illness. We determine critical illness using warning signs and scoring system. How can I know that this is a critical or not? There are some warning signs and scoring system which are identified to be used to know the critical case. Improve care for critically ill patients through the education, training, guidance, and protocols, or using cognitive aids. We will see what do we mean with training, guidance, or protocol. Identification of clinical process needed for essential emergency and critical care. Recognize components of hospital readiness needed for emergency and critical care. So to your hospital, to your setting, how ready are you to care critical cases? Analyze the gaps in institutional resources available for critical care, and then implement essential emergency and critical care with available resources. So there is no fantastic things say that because we don't have this, we may not have critical services, and you advocate for oxygen and additional emergency and critical care resources. This is our running objectives. And after the presentation, we need you back to your settings, to your hospital, to see how you can organize your departments to care for critical cases as the case presented today. Next, please. Next. To go through all those learning objectives, our four co-panelists or our four presenters, Dr. Joseph, Dr. Poner, Madame Liberata, and Dr. Venit, will help us, each of them having his responsibility to help us understanding step by step, point by point of our running objectives to go to take in our consideration of this essential emergency and critical care. Without spending more time about every presenter's role, let us go to the next, starting by Dr. Joseph, who is going to help us understanding the concept of acute care, critical care, intensive care, and explain to us what are domain of acute care and what is the critical care continuum. Always in mind the case presented as discussed in the previous slide. Dr. Joseph, welcome and help us to understand such concept.
Thank you, Xavier, and thank you, team. I hope everyone is hearing me. Where I am is, it's raining. Just give me a sign if you are hearing me very well.
Yeah, we are hearing you.
Okay, thank you. So just let's start by the healthcare service. So you know, all of us, we are working in healthcare condition, we are doing our patient, and the principal aim of healthcare service is able to contribute in improvement of health or the diagnosis, even treatment, and the rehabilitation of sick peoples. Of course, healthcare service are having several perspectives. So the first one is action to organize the input necessary for the provision of effective intervention, and as inclusive of promotion, prevention, cure, rehabilitation, of course, and palliation effort to our patient. And the last one is an orientation toward either individual or population. It means really we are considering our patient maybe individually, and then we come back to our population in general. So next slide to see some concept. So here we have concept of acute care, critical care, and intensive care, and emergency care. So at the end of my presentation, so really everyone will be able to understand that those concepts, how those one are working, what is the difference between them. So then let's go to the next slide and by the acute care. So when we say acute care, really we're saying service who are responsible to life-threatening emergencies or acute exacerbation of chronic illness. For example, a patient might have a chronic asthma and then it came in with really severe asthma attack, and it become really an emergency, life-threatening condition who need immediate intervention, and it's called acute care. So of course, also in acute care, it may be a routine health problem that require prompt action. And really, when we say acute care, really we depend really time. In acute care, a time is really sensitive and frequently rapid intervention. So it means in the case of acute care, we don't have much time to wait to intervene. So our patient is really dying. We need to intervene really rapidly in a short term. So let's go to the next slide to see the contribution of the acute care. So the acute care contribute much in our critical interventions. So acute care play a vital role in the prevention of death and disability. So of course, can get an example. If we receive a patient who is having a catastrophic hemorrhage, so really if you don't intervene rapidly, that patient will die. So the primary care is not positioned and is frequently unable to assume this role. So this means we need to differentiate acute care and primary care. So you might do a primary care to a patient, but the primary care, there's no component of life-threatening condition really, which need immediate intervention. So of course, in acute care may be a primary care, the primary care, but with a target of prevention of death or disability. And primary care really, it's a matter of time and the type of intervention which really will be delivered. So acute care also serves as an entry point of healthcare for individuals with emergency and urgent condition, and it allows the development of metrics for the evaluation of acute care service, the assessment of the disease burden in the service, and the articulation of goals for the advancement of acute care in low middle income countries. So, you know, our country also is in that class of low middle income country. Really, if our acute care policy and procedure of intervention really are strong, you will see how this disability, how this acute care will help us to prevent more death and more disability. So let's take a next slide to see with the critical care. So when we say critical care, especially as a definition to say it's a medical care for people who are having a life-threatening injuries or illness, and that area, a designated area of hospital which is providing the critical care, we're calling it intensive care unit, as simple as ICU. So here, everyone know what is an ICU. That place, what we're doing in that place, 1 minute to minute, day to day, that's critical care. So, and this critical care, the critical illness really should be just one part of the patient's disease trajectory and how the patient management before and after ICU admission has an important role to play in optimizing outcome. So, of course, identifying critical illness early before it reaches a stage where it is life-threatening. It means identifying a critical condition before arriving in ICU. It requires a combination of improved and more frequent or continuous monitoring of at-risk patients. So staff training to recognize when a patient is deteriorating. The system required a call for help. So I know we are working as clinician, as nurse, a midwife, and whatever. Really, when your patient is deteriorating and you call for help and the patient's help is really, that's a prevent patient to go in that critical settings. I say ICU. So the patient's continuum after ICU discharge must also be taken into account during the ICU stay, with attempts made to limit longer-term physical and psychological consequences of critical illness as much as possible. So it means if you are treating a patient in the ICU, just start thinking the patient is leaving the ICU toward even to home. Just help that patient, consider how the patient will be a kind of rehabilitation, the family, the ward, really, because this ICU place really, it's annoying, really. You know, it's really dangerous for the patient. And make sure you are preparing also a patient to continue his life after the ICU stage. So let's go on the next slide, and we see what we call emergency and critical care. So we thought the critical care is the condition where we are dealing with patient with life-threatening condition. And this emergency means immediate intervention, as long as it's a patient. So, and then the patient with critical condition require care and require it quickly. So if a patient really is seriously ill, so make sure you're going to deliver care immediate and rapidly. This will be called emergency and critical care. So emergency and critical care focuses on resuscitating a stable patient and allowing a time of recovery or the effect of a specific therapies to improve outcome and prevent death. So we use emergency and critical care in the broad sense of care provided to all critically ill patients. So as a summary of this slide, if a patient is really critically ill, it means there's in a critical condition. So you need to provide a care at your optimal level and to do it quickly without a delay. And this call it emergency and a critical care. So you can't separate them. So let's see the next slide to see what is the burden of the critical care. Next. Okay. So when we say burden of critical care, as you say, we are dealing with critically ill patients, who are already, who are not ready to die, who are about to die. And the global burden of critical illness is difficult to define for several reasons. First one, so critical illness cannot be diagnosed with a single test or linked to a single procedure. So critical illness-related diagnoses are made by using clinical exam, investigation, and often the definition and criteria are debated and changed until you get the final cause, the final cause of those critical conditions. Although critical illness occur outside of the ICU, using device
Dr. Joseph we're not catching you. It might be because of the rains. Dr. Francois or any of the other panelists, would you be able to fill in for this slide? Dr. Francois, Dr. Apollinaire, Dr. Venuste. Are any of you able to fill in for the slide?
Can you hear me?
Yes. Yes, we can hear you now.
Okay. Can I start where Joseph was talking about burden of critical care? The global burden of critical illness, most of the time it's difficult to define for several reasons, as you know, because it have to be defined by where someone is and the tool someone has to make a diagnosis. Critical illness, most of the time, it can't occur in the ICU, but it comes from outside to be managed in the intensive care unit. And considering where is from or how the ICU is set, the management may different, but the purpose of its management is the same. Next slide. As you have been saying, there is a global need for essential emergency and critical care. As you can see, this, the availability of those essential emergency and critical care will give us the outcome. Like early recognition, then early transfer and management within the ICU or from ICU to the ward for rehabilitation. Next slide. There are like several domains for acute care, but all of them, they are meeting to acute care. There is emergency care, there is urgent care, there is short-term stabilization, pre-hospital care, critical care, trauma care, and acute surgery. Those they are meeting to acute care, meaning that if there is early recognition, the pre-hospital intervene early, then the acute care is started, the outcome will be good. Those domains will lead to outcome if the settings will be having the minimal requirement to manage the case. Next slide.
I came back.
Okay, thank you. You can continue with definition of domain of acute care.
Sorry, it was because of heavy rain, really. I disappeared, even myself. I didn't know what happened, so I apologize. So let's continue what Paul was saying, those domain of acute care. So, and when you say, we start by trauma care and acute care surgery. So is this a treatment of individual with acute surgical need, like life-threatening injuries, acute appendicitis, or strangulated hernia? And when we say emergency care, it really is a treatment of individual with acute life-threatening medical and potentially surgical needs. So example of myocardial infarction, acute cerebrovascular accident, this is a stroke, the common term in our settings. So next, to see other domains, I will say urgent care. Next. So when we say urgent care, it's ambulatory care in facility delivering medical care outside the hospital emergency department, usually on unscheduled work in basis. So can I get an example of to evaluate an injured ankle or fever in a child? And when in hospital care in our Rwanda, we are called it SAMI, Service d'aide médicale d'urgence, hospital. So it includes care provided in the community until the patient alive at formal health care facility capable of giving definitive care. So this it means it's a care delivered during the patient transport. Then, so example, care provided the ambulance, personal, local health care provider at the community level from health center to DH fellow and other else. So let's go next. So we'll talk about continuum of care. So I told before in my presentation, so when the patient is in the ICU, so just we have also to continue where the patient came from and where the patient will live during at the ICU discharge. It means maybe in the ward, so ward to home. So it's that line called patient continuum. And it's a management of critical illness before and after ICU. Admission has an important role to play in optimizing outcome. So it means don't consider the care you are giving in the ICU, but also think how the patient will be, what the patient will receive out of the ICU. So, of course, early detection of the critical illness, it requires a frequent and a continuous monitoring of risk patients. Of course, you will need a trained staff on this continuum care. Of course, the system to call for help, and then effective response to call that call. It means if the patient is out of ICU, so just make a close contact, a call system of the ICU, even the out of ICU. If the patient or family member call you, make sure how you will respond immediately or which advice you will give to the patient. So let's go on this paragraph. So we have the two paradigms, the older one and the new one. So the difference of this, so the patient itinerary is the same from this pre-hospital service, emergency or flow, then the patient go ICU, then go into the ward. This is flow, this is a ward, then home, discharge home or rehabilitation center or whatever. It means the other one said that if you are in a pre-hospital, just do what you can do. And you leave the patient to emergency what they have to do, said ICU, without considering where the patient or where go after being discharged from your department. So the new paradigm said that if you are in emergency, treat a patient thinking your patient can go in emergency. And if you're in emergency, treat a patient thinking the patient outcome in ICU. And the same, you are in ICU, you treat the patient will be decided from ICU how will be in ward or the floor. Of course, if the patient is in ward, it means the patient is recovering, just start thinking the home care of your patient or rehabilitation. So let's go on the next slide. Let's go on the next slide and close my presentation by saying that the patient continuum after ICU discharge must also be taken into accounting during the ICU stay, with attempt made to limit the longer-term physical and psychological consequence of critical illness as much as possible. So this is my end of this presentation. Let's give time to others. And if you have a question, you can ask live in this chat. Then you can get more clarification, or if you have any suggestions on what we say, just welcome. Thank you. Are you hearing me?
We can hear you. Okay, I think I will be continuing with the essential emergency and the critical care. Okay, as we define essential emergency and the critical care as a care that all critical ill patients has to receive in the hospital worldwide. This concept is crucial as a part of universal health coverage, and it has some challenges in the low resources country, as you know, where the hospital, they are not equipped as in the developing countries. Meaning that the essential emergency and the critical care that someone have to receive in the developing country has to be on the same as low-income countries, but by using what is available in those low-resource countries. Essential emergency and critical care is divided into two domains. The first domain will be identification, and the second domain will be the care. The identification of this, of the case, first of all, someone who is identifying have to know where this case will be managed, so that, because the objective will be to get the good outcome. Next slide. As you said, the two domains of essential emergency critical care, there is identification of critical illness, and then the care of that critical illness within the hospital. Meaning that after identification, the hospital have to get its readiness, meaning the necessary facilities, infrastructure, required to manage that critically sick patient. The next slide. As you have been looking, the global need for essential emergency and critical care start with identification of the critical illness. If identification, you are not finding essential care of the critical care, if you get this essential care of the critical illness, there will be a good outcome. There will be effective coverage of essential emergency critical care, then stabilization of the patient, and then after stabilization, there will be treatment of the patient, and that will lead to a good outcome, where it's threatened survival of a critically ill patient. We know the patient admitted in, or who will be consulting as a critical, the survival rate in our developing countries is low, but if we can improve those identification and the essential care to be given, will lead to increase our survival. Next slide. How do we identify those critical illness? There is what we call a rapid response team, which is a group of healthcare provider who will be intervening for the good outcome of that critically ill patient. The quick identification and the response to the life-threatening condition of the patient will lead to a good outcome. This rapid response team is essentially multidisciplinary, where we'll be having nurses, lab technician, emergency physician, other doctors who will be intervening for the good outcome. After identification, there will be essential management. Then after essential management, stabilization. Then the patient will be admitted to ICU, and then there is continuous of care for that patient. Next slide. Okay, there is an element of essential emergency and critical care in the hospital. The point one, as we have been saying, it's the identification of that critically ill patient. There is the structures needed, like emergency department with the working triage system. There is a ward-based triage that will be the patient who is already admitted, but through continuous monitoring of the patient, we will find that he's deteriorating. That's the way to identify him or her. There is a trained ideal ward staff to identify those cases. Another structure in the identification, there is a clinical process needed. For example, at ED triage is conducted, then they find that the patient is critically ill, or in the ward, there is early warning score that will show us the patient is deteriorating, then he needs a multidisciplinary management or is in the need of holistic management. The point two is the essential care of critically ill patient. As we have been saying, after identification, there is what you have to do so that to lead to a good outcome. There is the structure needed for the hospital, like availability of emergency department, resuscitation room, emergency drug and equipment, oxygen training staff, guideline for this essential emergency care. The second point is the clinical processes. After identification or availability of those, the resuscitation room, there is the use of appropriate airway action if someone is having respiratory failure. Early use of oxygen in the case of hypoxia, use of intravenous fluid in the shock as early as we can. Next slide. The point three is the output of those essential emergency and the critical care as effective coverage of those essential emergency and the critical care. The point four is the mechanism through which essential emergency and critical care translate into increased survival of critically ill patient. As we said, if this patient is identified, the early management is done, and then the admission after recognizing of the diagnosis will lead to its survival. Point five, survival of critical ill at discharge time. We used to say the ICU, it's for reversible causes, meaning that if you admit a patient with no hope for a good outcome, we are wasting our time, we are wasting our resources. But we would like to reverse those critical conditions of the patient as early as we can. Next slide. Okay, there is a way to identify that our patient is deteriorating. We are using some guidelines, like at triage, we identify that someone is severely sick when we do pulse rate and we find that it's abnormal. When you do blood pressure, you may find that someone is hypotensive, then you think that is in shock. Early intervention will lead to a good outcome. There is a, when you measure the saturation, you may find someone is hypoxic, and then early recognition will lead to a good outcome. There is a temperature. You know that temperature, it's a good indicator of severity of condition. And then we have to know the level of consciousness. For our patient, it will be necessary to know if the patient was admitted, for example, someone who is in ward, and then the consciousness reduced. It means that he will be deteriorating. When there is abnormal airway sound, also that's also something to show that someone is deteriorating. In the patient, not only at triage, even during ward, he can deteriorate, meaning that's why the physician may guide the nurse who are monitoring the patient, do vitals every 3 hours, so that if there is a change, intervention will be done as early as we can. Next slide. Okay, the next slide is showing us care of critical illness. As we know, we recognize that someone is critically sick based on ABCDs. We know that if someone has airway problem or it's emergency, because someone will not sustain not to breathe in 1 minute. And then if you recognize that someone has difficult or airway problems, first of all, after identification, you have to do something. Pressing the patient to the recovery position, maneuvers to improve respiration, if there is a foreign body to be removed, or suction if there is a secretion within the mouth. If not, insertion of oropharyngeal airway. When you have settled the airway, you have to look on the breathing. You will be optimizing the breathing by changing the position or using different device to improve the oxygenation. If not, you will start back valve mask ventilation to improve your oxygenation. When the B is settled, you go to circulation and you optimize the patient position depending on what you think is causing this problem in the circulation. If there is a bleeding outside, you have to stop as early as you can. If you find that the hypotension, to get to IV line, it's mandatory and to start IV fluid. If not improved, you have to recognize that I have to use inotrope to improve our cardiac output. Next slide. From circulation, when someone has reduced level of consciousness, that's also something life-threatening condition, you have to know what is the cause of that condition. Sometimes we do dextrose to check if the glycemia is normal. Sometimes we check if the patient is not seizing, or if none of medication used can cause this reduced level of consciousness. For other care in the essential emergency and critical care, we have to consider, as I said, if someone is in shock, you have to put IV line and start fluid. If it's a kid and you cannot get peripheral line, you have to set intraosseous cannula. If the patient was involved in trauma, you have to stabilize the C-spine. If you think that someone is in sepsis, you have to start as early as you can and appropriate antibiotics. Sometimes in the trauma, we forget to think about the pain. Those patients also, they need a good painkiller to help them. Next slide. Okay, sometimes there is a use the framework to tackle emergency or to recognize that someone in need of emergency or critical care management. We use early warning score using the vital signs of the patient, where those vitals can help us to recognize that the patient is deteriorating. There is another systematic approach we may use to recognize or to identify someone who is critically sick using ABCDs. A, to look for airway, B, to look for breathing pattern, C, for circulation, D, for D for dextrose or level of consciousness. Sorry. There is other mnemonics we use: sample, signs of symptoms, medication, past medical history. And there's a special course like BLS, ACLS, PARS, ATLS, which help us to recognize all the life-threatening condition and how to manage that. Another framework to tackle emergencies is what we call the Glasgow-Coma scale for trauma patients, to know how to categorize how is our patient. There's also AVPU, where we look for alert, verbal response, pain response, or unconscious. Also, those are like key things can help us to recognize our patient who is very sick, so that we do a holistic management on time. Next slide. As you can see, the warning signs and the scoring system, the one we are using have 6 components: mobility, respiratory rate, pulse, systolic blood pressure, temperature, AVPU, or trauma. This one will give marks according to the results you are seeing to your patient. Excuse me. For example, if someone is coming walking, it will be different from someone who is coming with the help or on a wheelchair or coming on a stretcher. Also, this respiratory rate will read us where we can put our patient. Pulse also, there is a low pulse, high pulse, which will be indicating that our patient is in a critical condition. AVPU also it's a good indicator of a patient who is confused, alert, reacting to voice or reacting to pain or unconscious. If you find someone is unconscious, it means that he's very sick. And the trauma and the non-trauma will help us where to categorize or to narrow our differential diagnosis. If someone is coming after trauma and is unconscious, you think about something which is maybe a bleeding in the brain. I think that's the end of my presentation. Thank you.
Yeah, thanks, Dr. Pornell. We apologize because our network is not really stable. As you see, we are traveling in our Rwanda hills, but I hope presenters gave to you an interesting topic about concept of emergency care, some contributing factors to survival rate for critical patients, which Dr. Pornell now comes to present to you. So as now we don't have structured critical care unit at our settings, how to improve care of critically ill patients through education and training, guideline and the protocol, but also some cognitive aids. So how can we do to increase the survival rate of our critical patients in setting where we are without the fantastic equipment or supplies? Next, please. Talking about improving the critical patient management by education or training, the WHO, Basic Emergency Care, is strengthening about the trauma care, difficulty in breathing. Most of the patients, I think, in your settings where you are working, they're coming in respiratory distress or in shock. And as now in Rwanda, our roads are improved, trauma also is occurring daily. So you have to have, as Apollinaire presented, your structured a critical care unit where you manage the patients who come to them. And from the website of WHO or from our running resource center, you can load those topics and their courses online and go through in details. Next, please. After the education and the training, of course, you will need protocols, which will help you to manage the case the same way in different settings. Next, please. So now we are having some protocols. Next. Next. So now we are having some protocols for COVID testing. We are having protocols for infection prevention and control. We're having protocols for patient assessment. Again, for details, you see it on the screen. For the guidelines to now in critical care, we are the Society of Critical Care Medicine. We provide the clinical practice guidelines
Alana, if you're there, could you please request either Dr. Venuste or Dr. Apollinaire to take up this part, because I see Dr. Francois has dropped off.
Yes, Dr. Apollinaire.
Okay, I
Or
can
Dr.
keep.
Venuste. Okay.
Okay. As you have been looking on what we can do to recognize our critically ill patient, there are some guidelines. As we were saying about education and training, for example, guideline of survival sepsis campaign, we know that sepsis is among critical conditions that kill many patients. This guideline may help in setting up a guideline how we can manage sepsis in our hospital where we work. There is a 2022 Society of Critical Care Medicine Critical Practice Guideline on Prevention and Management of Pain, Agitation, Neuromuscular Blockage, Delirium in critical ill pediatric with the consideration of ICU environment and the early morbidity. As we saw while looking on our critical patient, we saw that pain management for patients who are intubated or management of delirium or agitation can help to give a good outcome to our patient. This also guideline may help how to organize our critical, our ICU. There is a protocol on COVID testing, infection prevention, and the control, IPC, PPE usage. There is patient assessment protocols. Not only we can have those ones from our Rwanda Biomedical Center or WHO, and we confer or we set our own at our working hospital. Also, there's details on many more protocols can be found on covidprotocol.org, where you can find IPC protocol, COVID testing protocol, PPE usage protocol, and the COVID patient assessment protocols. Next slide. Okay, regarding the cognitive aids may take, there is a poster, for example, poster how to wash our hands, poster how to put on our PPE. There is a flow chart, for example, for septic patient management. There is a flow chart. You do this when there is this. There is a checklist for some conditions, even mnemonics that we can use to memorize or to know better our patient or to recognize early our patient. Next slide. For example, this is a needs for ventricular tachycardia or pulseless electrical activity while doing our CPR. And then you can have like same posters in a working place to help us. In case there is this, anyone can read and intervene, and it gives a good outcome to our patient. Next slide.
Thank you, Dr. Apollinaire. I'm back, but I'm really sorry with this internet disturbance. I would like to thank you for your backup and invite Dr. to talk, to discuss with us the hospital readiness and planning for global need of essential emergency and critical care in the conceptual framework gap analysis for essential emergency and critical care and action plan ahead. Dr. Venice, welcome, and I will follow now.
Thank you, and the team, and people also
Very
in the
sorry
attendance.
for the interruptions of the internet. Yeah.
Can you please confirm if you are hearing me?
Yes, we are hearing you.
Thank you very much. So I'm going to talk on the hospital readiness for caring of critical illness, but also very sick patient with COVID-19 and how we can improve the healthcare systems by a good planification. So next slide, please. So generally, the hospital readiness for caring critically ill patients with COVID-19 doesn't differ with the usual readiness for other very sick patients. The only additional elements for COVID-19 is the care bundle for patients with COVID-19, but also uh, protective equipment that you use to prevent the spread of infections. So generally, the hospital readiness in caring critically ill patient has components that some of them we have seen in the previous presentation. And we have aspects of equipment, consumables, drugs or medications. We need human resources, training, guidelines, but also infrastructures. If we look in particular for critically ill patients with COVID-19, what we need in their care bundle, we need personal protective equipment to prevent infections and also control the infection. We need to monitor the oxygen saturation using the pulse oximeters at least every 6 hours, unless the patient is very sick and you need to check the vitals very often, like either 15 or 30 minutes or every hour. You also need to apply intermittent prone positioning. As you have seen, it will recruit the lung for improving oxygenation. As in the care bundle also for COVID-19 patients, you need to give anticoagulation as a prophylaxis, either with low molecular weight heparin or an fractionated heparin. We also need corticosteroids, as we have seen, they are the main medication that are going to address the inflammation from the COVID-19. Don't use the non-steroidal anti-inflammatory medication like ibuprofen or diclofenac, as they have been seen to be associated with poor outcome. You may also need antibiotics for patients who have bacteriospore infection. But generally, this is the care bundle you need to take care of patients with COVID-19. So in addition to this, the hospital needs some consumables like face mask, like N95 for airways protection to prevent the contamination by droplets. You need drugs, as I've said, the anticoagulation, the steroids. You need the staff which is trained for caring critically ill patients with COVID-19. And then you provide guideline for COVID-19, but also you need rooms for separating patients with COVID-19 from others who are negative. Next slide, please. Yeah. So in the essential emergency and critical care, we may have gaps generally in all health facilities. So there is the reality we are having, but also there is the best practice that we are intending uh, in identifying those gaps and planning for addressing those gaps. We use two frameworks. One is SBAR, which is the situation of the problem, the background of the problem. You need also to see the assessment of that problem, and at the end, you provide recommendations. But also, you need to explore the strength that you are having in the system, try to see the opportunities, but also look on the side of things that may harm or may impede your plan, like weaknesses, but also threats. If you take an example, a nurse may be in a situation where she's seeing a patient who is having a low blood pressure, and that nurse is going to see the background. In the background, the nurse may report that the patient was admitted with fever or with respiratory distress or cough. Then in the assessment, the nurse may try to think could be the cause of that low blood pressure. And you may think of septic shock or sepsis from pneumonia. And then the recommendation could be the nurse calling a doctor to come and assess that patient or to transfer the patient to the ICU. In the Do you hear me?
We can hear you.
So the second strategy, which is SWOT, which is the strength. In the system, the strength might be like a expertise or the experience of the staff, but also technologies that we are having in the system, like having a room for MRI, CT scan, interventional cardiology or interventional radiologies. These are the strengths you can build up to try to address the clinical problems that the patients are having in the healthcare system. So the weaknesses could be like you're having like new insurances that are changing their plans of operation, or you have an adverse increase in the demography of the total population. That could be a weakness or a threat. Opportunities could be like having new services in the healthcare system, or you're having new technologies that are going to help you to address certain clinical problems for your patients. Next slide, please. So the aim for all of this for the healthcare quality is to have improved the patient care, improve the population health, but also reduce the cost. To reach this, you need a meaningful use of people, process, and the technology to have a continuous quality improvement. So the process here, I mean detecting the clinical problems for your patients, diagnosing them, treating them, providing end-of-life care if they are needed, to try to change these inputs into the outputs. And these outputs we need is the improved care for your patient, improved health, but also the reduced cost or the cost effectiveness of the service. Next slide, please. Let's go to the next. Yes. So we have gaps in our institutional resources to, to apply the essential emergency and critical care, but we have to try our best to address these gaps. Some of the gaps we're having on the staff space system. Regarding the staff in Rwanda healthcare system, in many district hospitals, we are having inadequate number of health personnel. For instance, anesthesiologists, critical care physicians, emergency physicians, cardiologists. And you can think of consequences that a patient may face if they really need emergency intubation and there is no one at the site to provide that rapid airway management. So this gap is, to address it, it requires a process from the Ministry Human Resources Board by increasing the number of trainees in the residence program, general medicine program, nursing care schools. It's a process, and in Rwanda we are seeing improvement of on this aspect. So regarding staff or materials, in remote areas, certain diagnostic capacities are lacking, like available blood cultures, arterial blood gases, MRI, anatomical pathologies, but there are also others. So in this essential emergency and critical care, mainly we are dealing with trying to detect a patient who is going to deteriorate, but also stabilize. But after stabilizing your patient, you also need someone who is going to provide definitive treatment. And some of the definitive treatment might be guided by those blood cultures, the availability of arterial blood gas, but also results from MRI, but also results from anatomical pathologies. That's why I took it as we are having in many of health facilities that we have remotely. So in terms of space, some of the barriers we are having is that the emergency rooms does not have space for resuscitation, for instance. If they have like 3 beds, none is designated for resuscitation, and you may struggle to move your patient to a safe place where you can do a successful resuscitation. And if you are not having enough space, it could be a barrier for IPC, the infection prevention and control. So regarding the system, the main issue we are having is the long distances that complicates the transfers if you want to escalate the care for your patients who is very sick. Because the ICU beds are not readily available in many health facilities. The high dependent unit are also lacking in a big number of district hospitals. Next slide, please. So no matter these challenges or threats, you have to be ready and do what you can where you are and with what you have. Try to use the vital signs, interpret them, use the minimal investigation you're having, the minimal clinical evaluation or physical exam you're having, and single out or detect someone who is going to deteriorate and try to alert either the emergency care team or the resuscitation team, or if you want to transfer, you call the necessary personnel to help you or assist you to transfer your patient as early as possible. Next slide, please. Yes, some of the action plan we can take to try to improve the essential emergency and critical care. Here we are having example of respiratory distress. So some of the real situation we are having in many health facilities is that there is no standard policy for SpO2 monitoring. And the best practice could be like including the SpO2 as a fifth vital sign in all vital signs. And you need to record the vital signs regularly at the intervals designed by either the treating team or the protocol for the condition of the patient. But you also need to notify the medical doctor regarding any abnormal vital signs. So this could be the best practice for respiratory distress. So the gaps that are seen, examples are that they are no vital signs policy. We don't have abnormal or vital signs recognized, like the interpretation is a barrier, but also there is a consistency in reporting the abnormal vital signs, either to senior nurse or to a doctor or to a specialist if you need to report. So some of the action plan you can take is that you specify that SpO2 should be part of the vital signs and specify the interval time you need to record the vitals, either if a patient is in medical ward or surgical ward, in emergency, ICU or PACU, or if a patient is in operating room, how often do you need to record the vital signs? And of course, you end up by setting a monitoring and evaluation tool, and this can be achieved by trying to chart the vital signs and review those charts for interpretation. And you also need to retain the running assessment and like kind of feedbacks. And then you have to assess the patient's outcome by doing evaluations and see if these measures has improved your patient's outcome. So there are a lot you can do on all aspects of clinical signs that alarm you that the patient is going to deteriorate, and try to set your goals for the nurse, for any doctor who is rounding on that patient. Next slide. Yes, regarding the implementation of essential emergency and critical care with available resources, number one is to understand the burden of a critical illness. If a patient is having organ damage, you have to know that it can have a severe implication on the morbidity, but also the mortality for that patient. Then you try to use the clinical exam, the available investigation workup to detect those patients who are very sick, and you provide timely interventions regarding either tests or treatments. Then you try to develop the rapid response teams in the health facility to address the critical problems. Let's say if you detect a patient who's having like a massive pulmonary embolism, if you have a rapid response team for pulmonary embolism and you alarm them, they know what to do, and the patient is held in the good time frame. Then of course, in this essential emergency and critical care, the communication in the multidisciplinary team is essential for decision making. If you need your patient to be evaluated by a respiratory medicine team or the ICU team, it is done quickly if you have done a good communication. Next slide, please. And of course, in the era of COVID-19, we have seen that oxygen, despite being one of the essential medications in the all hospital formulary list, it is still inadequate in many health facilities. And for COVID-19, it's #1 medication you are going to use if your patient is having the severe form of COVID-19 or any other critically ill patient. So the demand for oxygen is increasing worldwide, and it's even worse in low and middle income countries. So, and this access has been neglected in many parts of the world. So this time we need to see how we can involve the country decision makers. Here I mean the local government authorities, but also the global health partners, to see how we can increase the oxygen plant in health facilities so that any patient who is requiring oxygen is going to be facilitated. So I think this is the least but not the last slide of my presentation. If we have questions, it's time to have questions or the feedback or any comments from the audience before we have the general take-home message from Dr. Sapien. Thank you very much.
Yeah, thanks, Dr. Venice. I hope the presentation was so interesting and very clear. If anyone has a question, you can put it in the chat. We are going to answer on it. I hope from this presentation, which today has an important message that if you don't have an organized emergency and the critical care, please, it's time to go and assess your gaps. Try to see which solutions you can implement. In terms of 4S, as Bill Gates stated, staffs, space, and the systems. And I hope from today, everyone understood what is acute care or critical care in general. The domain of critical care is very broad. Everything you are doing to your setting, to your hospital, to your center, to your post are included in this kind of critical care. Please try to organize your critical care space. Try to invest in your critical care staff. Try to improve your critical care system and try to improve critical care space. As you found me having this disturbance in internet connection, I was just monitoring or looking around the country how emergency care is being done, but we still have a problem of structure, problem of staff, problem of system there. So from today's message, please think about critical care, think about those critical patients. As Dr. Poinel said, when they come to referral so late, there is nothing to do because of delayed identification, because of delayed critical care. That is our responsibility now to go and improve our critical care services where we are. Dr. Venice talked about strategy you can use in correcting your gaps and then improve your system in managing critical care. Where there is no possibility to improve, please, advocacy. We need to advocate for this kind of critical care domain. And then I hope we will be ready to know what to do. The message now today or assignment today, go home, go to your setting and assess your setting, your hospital, your health center readiness for managing critical care. Otherwise, let me inform you that our last session will be on 3rd March and it will be session 12. We will be answering on different questions from session 1 to session 12. Go back, read through all our presentation from October to now. And after that 12th session, we will be preparing your general certificate and global CPD to whoever attended 9 out of 12 sessions and who will obtain more than 70% from the exam which you are going to prepare to give to you who had the chance to attend or who had not enough chance to meet the 9 out of 12 session attendance. You may not have that time, but as after the presentation, we are sending you the reference to read it through, and you may be able to answer to our questions. Please, you will also be candidate to our certificate and the CPD. And I hope if Alana has another, let me see on this. What is the current COVID patient treatment algorithm being used currently in Rwanda, and also consideration in case of medevac of the same kind of a patient? Thank you, Mr. Mikhail Gitau. Today we are talking about organizing emergency and the critical care. And the COVID we talked about in the previous sessions. But to answer to you, in Rwanda, today, we have 1 week without a critical case, without a case admitted in our COVID center. So, but we are still ready. We are having a standby hospital in Nyamata now, and we're having standby staff who always every day are at the hospital waiting any COVID case. Any COVID case arriving to our hospital, any COVID case arriving in these days, we are still following the algorithm from the previous 3 or 4 editions. The 4th edition of COVID management in Rwanda is still in consideration. Whichever kind of medevac or whatever the patient will be presented, we are ready to help, we are ready to manage. That hospital, that ready hospital is waiting the patient if the case presented. Mike, I think any COVID new case, we are ready to do our job. The essential here is that be ready every day, be ready in your organization, be ready waiting that the critical case will come the time we don't expect. So reason why the message today is go back and look around you and see how ready you are to care a critical case. Thank you. And Alana, if you have any other message, but this time also some clarification about certificate to our spokes, certificate to our co-panelists. I think is a time to give them a message as our last session will be in 2 weeks to come, not in April, but in March on the 30th. I hope the time is up to you. And thank you.
Sure, thank you. Thank you everyone for participating today. Next slide, please. For certificates, we will be working on sending those out in the next few weeks. If you attended sessions 1 through 10 and did not receive a certificate, we'll ask you to let us know during our last session, and we'll write your name down so that you can get that. But we are going to be working on sending them out over the next few weeks. If you attended 75% of all sessions, you'll also get an additional certificate of course completion to reflect that engagement. But otherwise, we are thankful for your participation and thankful to all of the panelists for their efforts. And we hope to see you in 2 weeks. The next slide shows the date. Next slide. Oh, this is wrong actually. The next session is actually March 30th. I don't know if you're able to change that really quickly, Alvin, but session 12 is on March 30th. And the topic will be frequently asked questions and resources on oxygen therapy and critical care. And we'll send out some reminders from them as well. I'm seeing some messages in the chat about not receiving certificates. Just send me a WhatsApp message. I'll put my number in the chat and we will sort that out for you. Thank you, and hope to see you in 2 weeks' time. Goodbye.
Yeah, see you in 2 weeks. Thank you.